Dr. Kevin Yuhan is with us today. We welcome you, sir, to the show.
Oh, thank you very much.
Ophthalmology, the practice of treating the eye.
Yes.
A bit about your background, where you studied.
Well, it's a long story, but the short end is I started off as an engineer. I grew up locally, I went to El Toro High School, and studied engineering at UCI.
Okay.
After I graduated, I ended up working for Unisys and AT&T Bell Labs.
Yeah.
Didn't seem to be that fulfilling, so I ended up applying to medical school. Went to the University of Pennsylvania for medical school. Went to UCLA, the Joel Stein Eye Institute for my residency training, and then Johns Hopkins for my cornea fellowship. Wow. Landed right back, right next to where I originally started working, Unisys, and Kaiser is right next to Unisys, so it made a full circle.
Well, the commute should be easy for you. You know how to get there at least.
Exactly.
That's amazing. That's a great story. Well, because we have a lot of doctors now that obviously started somewhere else and ended up here.
Yes.
You're one of those rare ones that has come full circle, so to speak. That's great. Along the way, you've obviously trained in some prestigious locations, including Joel Stein right here in Southern California, which is very well known, very well respected in the ophthalmology field. So obviously the training you received is very, very good. We're going to talk about a specific problem today that I guess is any of us over 50 need to be thinking about this. It's something that we may have, and I guess if we live long enough, maybe we all will get it, and that's cataracts.
Yes.
What is a cataract?
Well, the word cataract comes from it means a waterfall. And originally in the 1700s, they thought that a cataract was because of an opaque humor or opaque fluid that was circulating inside the eye. So that's where the word actually comes from. But what the cataract is it's a opacity of the lens. And
let's leave that real still for a second so we get a shot of that on camera. Leave the whole model still.
Okay.
And we'll just put that little guy right back in there. That's great. Okay. So what we're looking at actually is a cross section here of the human eye, and the blue part we see in the front is what we see looking at the eye. The hollow part in the middle is where the black part would be if it were there, and then the part you're going to pick up is the lens we're talking about.
Exactly.
That's where the cataract arrives.
Exactly. It's a opacification of the crystalline lens.
Okay.
And as we get older, the crystals and the density of the lens starts to increase, and it creates an opacity. It starts to yellow, and as a result, as light comes through from the front of the eye through the pupil, instead of focusing light on the back of the retina, it diffuses the light. And so the symptoms that we typically see with cataracts, we see glare, a decrease in vision, a change in colors, especially with higher colors in the higher spectrum, such as blue and green. So patients start seeing things more with a red or orange tone. And patients could also see multiple images where there are different facets inside the lens, such as impurities, creating double vision or multiple images. And also, patients could just in general have a lot of blurred vision. So what they tend to do is they tend to go to the optometrist thinking that they need new glasses.
Stronger glasses.
And their optometrist tells them, I can't help them anymore. You need to get or some type of surgery done. Right,
and so they come see the ophthalmologist, which is you.
Exactly.
And the procedure takes place. Now, I understand that the techniques have evolved and changed, but now we're at the point where I guess nothing is routine anymore in medicine, but it's actually not the hospitalization procedure that it used to be a few years ago.
Yes, exactly. A lot of the surgery has now become what we call ambulatory, in and out surgery, as people say.
We have this chart. I'm going to pick it up and hold it here. I guess I'll put it in front of me so Ken can shoot it. This first picture here really shows the beginning of the actual surgical procedure, correct?
Yes.
All right, so that's what you do. I guess there's obviously some kind of a pre-surgery procedure you go through first.
Yes. In terms of the pre-op clearance, a lot of patients think that they need to have blood work and EKGs performed, but in fact, we're finding that it's fairly a safe procedure, and a lot of those pre-op testing are not required, or the pre-op testing is not required. Really, from an eye standpoint, most insurance companies look at the overall visual acuity. It's called the best corrected visual acuity. If the vision is 20/40 or worse, we start considering planning a cataract surgery. The reason why 2040 is a number that we hang our hats on is because that's the minimum visual acuity to drive in California.
And I guess that's part of the motivation to come see the doctor is, I'm worried about passing that driving test next time.
Exactly.
So that's maybe what gets people to see you. They may have been dealing with this for years. It's a gradual process in most cases, I guess.
Yes.
Although I guess it can be sudden as well. All right, so the first thing we saw was an instrument going in there, and that's actually removing the cloudy lens, the natural lens.
Exactly.
Okay, the second picture that we're going to have is shows the actual installation of the lens. And very, very small, and it looks like it's rolled up.
It's rolled up like an enchilada.
Okay. And that's what allows you to do it with a minimum incision.
Exactly. In fact, when we do the incision, we make the incision. Can I point to the board? We make the incision at a place called the limbus. The limbus is between the cornea and the white part of the eye. And
okay, let's hang on a second. I'm going to put this down because my mic just fell off, and I believe yours did also, Doctor. So we're gonna have dual no mics here for a couple of seconds, folks. We apologize for that. All right, mine's back on now. So we've emulsified the old lens. It's gone. You vacuum that out under mild sedation.
Yes.
Obviously, the person's seeing very blurry at this point, if anything at all, but they're relaxed and they're comfortable.
Exactly.
And then you're installing, as you called it, this is what we're talking about. A guy like this, that would be, I can't roll it because this one's really stiff.
Exactly.
This is a obviously gigantic version of what you're putting inside the eye.
Yes.
The actual one is, I guess, smaller than our little fingernail.
The actual one is very small.
Oh, here, let me hold it for comparison. Okay, this is the guy right here. It's got kind of a yellow tint to it.
Yes.
And this has actually got the little loops on it as well, so you can see how tiny that is. Comparison right there, that little thing on top. Now, my understanding is also there's some variety out there. This one that you showed the model of actually looks like this with the loops on this one.
That's called the Acrosoft lens, made by Alcon Laboratories.
Okay.
And
well known in the eye care field.
Yes, well known. This is the traditional monofocal lens. The monofocal lens allows you to see both either distance or near, and that's pretty much the standard that's out in the industry now.
Right. So if somebody were having both eyes done, and usually these are done over maybe a month in between or a few weeks in between procedures, you would do what? One for nearsighted, one for far, one for near, one for far?
It all depends on the individual.
Okay.
Some individuals come in and they'll say, you know what, I want both eyes for distance, and I don't mind wearing reading glasses.
Okay.
Some will say, I want my dominant eye for distance and my non-dominant eye for near. And then others will opt for something called either a resume lens, a restore lens, or a crystal lens. And the crystal lenses are a new technology in which, or the set of three, a new technology that allows you to see both distance and far simultaneously.
This first type is, I guess from a camera standpoint, what we would call in video and film and television a fixed lens.
Exactly.
This would be different technology, but more or less like a zoom lens.
We call it a dynamically focused lens.
Okay, medical term. But yeah, it allows you, and I guess your eye muscles that have maybe been sitting back being sort of lazy with glasses for 50 years get a little workout now.
Exactly.
And there's a bit of getting used to this.
Exactly.
Yeah. The other aspect of it, you mentioned insurance. Most insurance companies, if you can get a letter from an ophthalmologist saying this person needs this, we'll pick it up. For this one, the fixed lens. And you can do, is that, I guess, monovision or whatever, but you would do
monovision is one
new
option.
And close. You know, I know with LASIK they do that, with contact lenses they do that. So that could be an option for the patient. But if they want to spend a little of their own money, they can go with this. This is a little more expensive procedure. The procedure's the same, but the lens is more expensive.
Exactly.
Right. And this is fitted the same way, the same procedure, but after a few weeks of some training, you get that focusing back in.
Exactly.
Right, right. You do these right here locally?
We do it in Irvine.
Okay. So it's not weeks in the hospital, it's not the sandbags, all that stuff it used to be.
No longer the sandbags.
Right. We're all concerned about risks in any kind of medical procedure. You've been doing these for years. Risk factors?
Well, with any type of surgery, there's a risk of bleeding or infection. We try to prevent that from happening by putting patients on prophylactic antibiotics, and primarily they're eye drops. Right. Before and after surgery. Other than that, I would say the The main risk usually occurs if there's underlying eye disease. Patients who have diabetes, patients who have macular degeneration, glaucoma, it increases the risk for not having the optimal surgical results. And with any eye surgery, there's no guaranteed results.
Yeah.
I would say approximately about 99% of